lecture. Try to get a B in lab, but it's not that critical. So don't stress over the lab, please. Do your best, but don't stress over it. Okay. Was that contradictory? Do your best, but don't stress. So, okay. So if you don't want to, just go into the content section of eLearn for the lab, and you'll find study guides at the bottom of the content section. You'll find the lab guide up right underneath this, right in the section with the syllabus. So, okay, let me get back to where I was. Stop sharing. Go into Skull. Okay. Anybody have any questions before I go on here? Okay, human skull. Human skull has 22 bones. It's part of the 206 bones in the human body. The good news is that everything in the left side of the body is matched by what's on the right side. So if you learn the arm and the leg and the hands and the feet, you've got the other side done too. That's the good news. The bad news is there's a lot of bones to learn now. 22 of them, though, are in the skull. Typically, the bone test focuses more on the skull than the rest of the bones altogether. Usually about 40% of the bone test covers the bones of the skull, plus all the little openings and passageways and things like this. The skull is a very complicated structure. You all should have one in front of you. This is what a skull looks like. This is one of those panoramic X-rays that you get when you go to the dentist. They do the whole all the way around. What I like about this is not only does it show you the whole skull, but you get to see the cervical vertebrae, and you get to see the ends of the collarbones, the clavicles, and you get to see part of the sternum and part of the ribs too. So you actually see the cervical and part of the thoracic vertebrae. So I often wondered about that big dark spot though in the side of the skull, what that is. Yeah, so anyway, the skull, the very first bone that we look at in the skull is called the frontal bone. It's in the front. Imagine that. Everybody's got a skull in front of you. The frontal bone is right here. It is this region of your head. It's right underneath this skin. There's not much skin and muscle there to protect it. In fact, the muscle that's there is all about expression. Our facial expression muscles are located here. They tell us when we're annoyed, when we're bored, when we're tired, when we're happy, when we're sad. All these things are expressed because those muscles up here don't do a whole lot else for us. But the frontal bone, this big bone in the front, it goes from halfway back in the skull all the way down to the tops of the eye orbits. It covers the very top of the nasal cavity. So nobody ever gets the frontal bone wrong on a test because it's right there in the front. It's the frontal bone. So now we can see some structures here. This is the eye orbit. This is just below the frontal bone. We have two orbits, one for each eye, and the eye fits into the socket there very nicely. You can see there's some openings in the back of the orbits. That's for the passage of the optic nerve and another nerve that goes through there. We see a structure here, a notch. If you take a look at your skull, you'll see a little notch about the middle of the orbit, above the orbit. Let's see if I can bring it up here on the camera. So if I take this skull and the orbit, this little notch is located right about here. I don't know if you can see it very well or not, but right about here and here, there's a notch. Now that notch is called the supra-orbital notch. The term supra means above. supra, above. Now in anatomy, if you have something that says supra, you got to have something that says infra. Supra means superior. So if you have superior, you have to have an inferior. If you have supra, you got to have infra, which is the abbreviation. Infra means below. Anatomy is consistent like that. If you have lateral, you're going to have medial. If you have superior, you're going to have inferior. So here we have the supraorbital notch, and its counterpart down here is the infraorbital foramen. That's a hole in the bone. Foramens are openings. Opening in bone. And it's nearly always for a passageway of a blood vessel, an artery, and a vein, and a nerve. So in some places it can just be for a nerve, but usually like going to the skin like this one is going to, would contain an artery, a vein, and a nerve to innervate the tissue on top of the area around the orbit. So this is the infraorbital, meaning below the orbit. Supraorbital means above the orbit. Here we see that little hole there, that the arrow is sort of off center, but there's a little hole in the back of the eye socket. That is the optic foramen. Any guesses what goes through the optic foramen? The optic nerve goes through the optic foramen, and it goes through there and directly into the brain, because the brain is right behind those two openings, or it would be anyway. So that is the optic foramen. Now, in front of the optic foramen, on the medial side, on the inside walls of both orbits, both sockets, there's a bone called the ethmoid bone. The ethmoid bone goes all the way across from one side to the other. It also extends up into the base of the cranial cavity and extends down into the nasal cavity. It's a pretty large bone. So our ethmoid bone is located right here. You got your skull there. It is directly in the optic foramen is right there, right here. Let's see, there we go, a little hole there. And the ethmoid bone is right in front of it. So, but it's a large bone and it does a lot of things for us. So there's the ethmoid bone. There's the frontal bone. Now behind the frontal bone on either side, right up to the midline of the skull are the parietal bones. There's one on each side. You can see, if you look at your skull, you can see the frontal bone, and then there's this squiggly little line right here. And then behind that are two other bones on top. And those are the parietals. They cover the parietal lobes. The frontal bone covers the frontal lobe of the brain. And the parietal bones cover the parietal bones, lobes. Here's another one of these little bizarre bones that doesn't look like it does anything, but actually extends all the way across the skull. It's called the sphenoid. Sphenoid bone is found right behind your eye. You put your finger on the side of your head, you can feel the edge of the orbit. You can feel where a bone comes down to on your cheekbone and come up just above your cheekbone. And you're going to find your sphenoid bone. It goes all the way across from left to right side. It extends up underneath the brain. It holds the pituitary gland, and it extends down towards the base of the skull too. So it's another one of these unusual, very large bones. When we look at it inside the skull itself, it's called the bat bone, or the batwing bone, or the Batman bone, because the sphenoid bone is shaped like a bat once you see it inside. Now here's the temporal bone. The temporal bones are on the side. here and here, right about the location of our ear. In fact, if you look, there's an opening on each side. There's a hole going into our skull. That is for the auditory nerve to pass through from the ear, and that's in the middle of the temporal bone. So your temporal bone is right along here. If you know where your ears are, you found your temporal bone. Now this bone here that forms our cheekbone is the zygomatic bone. It's this bone that runs along here to the sides. But you know, if you know where your cheekbones are, you feel your cheekbones, that's the zygomatic bone. It runs below the skull, or below the orbit, runs back along the side. You know, and depending on the shape and size, you know, it gives it determines the appearance of the face, you know, particularly around the eyes. Okay, now the front of the skull, if we move a little further down towards the front, we find the lower jaw. This is the mandible. And everybody should have a mandible out there. I think you didn't get one, I'm sorry. So, but we've all got one. It's our lower jaw. The mandible is the portion of our mandible. It is the mandible is the portion of our jaw that moves. The upper jaw is called the maxilla. The maxilla is actually part of the skull itself. The upper jaw doesn't move. The upper jaw has 16 teeth. The lower jaw has 16 teeth. The lower jaw will move up and down to two things. If one of you has a skull with the jaw attached, I think you do back there, you could actually, you know, you can get it to two things if you wanted to. See, yeah, there. Nothing like science in action, you know. But that's how our jaw works. We have several muscles, and we'll talk about the muscles later on in lab. We'll talk about how the muscles attached to our jaw allow it to be pulled up so that we can chew. We crush food up between the two between our teeth in the upper and lower jaw. So that's the mandible. The mandible has this big flat area in the front, and then we have this notch area here called the mandibular symphysis. The symphysis is an area where two bones come together. Now, in this case, there's no gap between the bones. This is, you know, see, when we're in utero, you know, we have our full skeleton in place by 6 weeks after conception. At that point, we start laying down bone. Now, the hyaline cartilage model of our bone has a left and right side for the mandible, just like our frontal bone has a left and right side in cartilage. The frontal bone up here grows together into one big bone. The mandible grows together into one large bone too. But where it was growing together is what's known as the mandibular symphysis. And so there is no gap. Other parts of our bodies where we have a symphysis, there is a gap. At our pelvic girdle, down at our hip bones, we have a gap at the pubic bones where they come together, and there's a big pad of cartilage in between. We use that for shock absorbing, so that when we move, when we walk up and down stairs or run or do anything like that, the friction and the stress of the action is absorbed by this pad of cartilage. We don't need that here. So there never was, you know, it just grew together. So that's the mandibular symphysis. Mandibular angle, that's a clever name. It just, because it has to turn and go up so it can articulate against the base of the skull. Articulate is a term we use when one bone rubs up against another bone. They articulate together. Mandibular ramus. Now, there were a couple of foramens here in the front of the mandible, one on either side. And, you know, we would think that those would be the mandibular foramens. That would be conventional wisdom. But no, the early anatomists decided that the mandibular foramen is going to be on the inside of the mandible. Oops, let me go back on. And so you can see if you open up your jaw and look, you can see some openings there on either side of the mandible. That is the mandibular frame in there. And again, it's a passageway for a blood vessel and or nerves, or both. Remember that bone is living tissue. 40% of bone is organic, and that's all made up of living cells. They're trapped in the hard bony matrix, but they're alive because of all the blood vessels that are supplying them nutrients and oxygen and taking away waste products, and the nerves that are telling them, hey, here's what's going on. So it isn't just passageway through to the skin, it's also to those bones, or to those bone cells. Okay, now this squiggly line across the top is called the coronal suture. You can see it on this one, it's outlined in red. You've all got suture lines on yours. The coronal suture is where the frontal bones and the parietal bones grew together. It is an immovable joint. It's a joint that does not have any flex or give to it. It didn't stabilize completely, probably till we were in our late teens or early 20s, because our skull is very flexible up until that, as it gradually calcifies and converts to bone. But the suture line would have given us some give. At childbirth, that would be very good, have a little give coming out through the birth canal. We have a little give because our brain grows as our body grows. And so we have some give here on the shape of the skull, because after all, this is the size of our skull when we're in utero. This is about the size of a baseball. This is a fetal skull. It's not real, by the way. But this is our skull as an adult. So we got to have room to grow. And so we have this flexibility with these sutures. A suture is simply what we call an immovable joint. And wherever the bones have grown together in the skull, we're going to have suture lines. They're all identified, little squiggly lines there where they've grown together. There's our frontal bone, parietal bone, temporal bone, zygomatic bone. Of course, it won't tell me what the suture lines are on this one. The suture lines represent where the bones have grown together. They are a very strong joint. We consider them to be an immovable joint. So we have suture lines between frontal and parietal and temporal, parietal and occipital down here. The coronal suture is probably the easiest to identify because it gives you that front and back that you see in a coronal plane, where you have the anterior portion and the posterior portion. In a minute, you'll see a sagittal suture that runs down the middle, giving you a left and a right. Okay, so now this is the occipital bone. We've seen all the bones of the skull now. The occipital bone covers the back of the skull, and it goes from right about here. You can feel a notch back here. You feel that notch, and it goes all the way down to the underside, past this very large opening in here. The spinal cord passes through here to get to the brain. So our occipital bone is very large, very strong. It protects the portion of the brain where we have our visual center. Because after all, remember, we see with our occipital lobe, our eyeballs only collect light rays, but the occipital lobe of the brain tells us what we're seeing. So the eyeballs have no clue what they're looking at. Okay, there's the squamous suture separating the parietal and the temporal. And there is the lambdoid separating parietal and occipital. Now here's another bone that nobody ever gets wrong. This is the nasal bone. And you can feel it, it's the top half of your nose. The bottom half of your nose is all hyaline cartilage and it's flexible. The top half is bone, nasal bone. And this is why our skeletons look like our nose has been cut off, because it has. The soft tissue doesn't last. You know, a skull will only show the bone left behind. So the actual bone actual nose probably extended out further along in here because it was hyaline cartilage, and soft tissue, unfortunately, doesn't last very long after death. Okay. Now this is another structure you can feel. Stick your fingers behind your ears and you'll feel a bump on each side. That's your mastoid process. The mastoid process is does two things for us. There's some very powerful muscles that attach to the mastoid process that allow us to turn our head to left and right and to nod it up and down. We'll talk about those muscles when we get into the muscle section. The other thing the mastoid process does, it's sort of an alternative sound collecting device. Because, you know, while sound comes in through our external ears, through the ear canal, into the inner ear, and we stimulate the auditory nerve to send a nerve impulse to the brain. The other way sound comes into our inner ear is through the mastoid process, because the mastoid process is very spongy. It looks like a honeycomb. It looks like it has lots and lots of holes in it, and sound will strike the bone and pass through the bone to the inner ear. And it's a very useful approach. If you put your fingers over your mastoid process and try and talk, your perception of your own sound is different. Because when I do this, I sound different than when I do this, even though I don't, you know, I think I sound different. This is my perception of how I hear, because I'm altering what my inner ear is picking up this way. So it's usually the location of cochlear implants, you know, the artificial ear, the artificial external ear. It usually placed right in here. And we will, later in the semester, we'll do some demonstrations with tuning forks, just to show how well the mastoid process does pick up sound waves and transmit to the inner ear. So, so that's the mastoid process. Very distinctive, large bump right here. A process, by the way, that's a good bone term. Process. So we can't think of any other term for something anatomist. Name it a process. Bump. Yeah. So now this pointy thing is another process. This pointy thing is called the styloid process. Came from, again, early anatomists used what they described it. Well, it's a sharp, pointy thing. It looks like a stylus. In those days, they were writing on clay tablets with sharp, pointy sticks, and they would write on the tablet, and it would be hardened into the clay, and they would call it a stylus. And the term stylus came out of this sharp, pointy structure. Later, it became the needle on a turntable that you would play a record with, believe it or not. You know, that many record players have a little needle in there. They call it a stylus that you would use to place your vinyl record on there, and how you could trigger the sound to be developed. You know, so. And we use a stylus on our tablets. It's so funny, we have come full circle on the stylus, because now we're using a stylus to mark on our tablet again after, you know, 1,000 years or whatever. Anyway, stylus is a sharp, pointy structure, and it's used to attach muscles to the bones. Muscles attach to these bones so that they can pull on something. We have two of these styloid processes in our skull, and when we take a look at our forearms, we're going to see a styloid process on the end of each bone. Each of the two bones in our forearms, the ulna and the radius, each have a styloid process simply to attach muscles to bones. It's just a pointy structure. That's all it is. It's nothing. It doesn't do anything dramatic for us. It's just there. The story about it's more interesting than the styloid process itself. If Okay, here's the ethmoid bone again. You can see there on the side, and directly behind it over here where it says number 10 is the Batman bone, the sphenoid bone. Here's another one that you might notice, lacrimal bone, has a gland that comes out of there. The lacrimal gland secretes tears to keep our eyes washed. You know, we're constantly washing our eyes every time we blink. We are cleaning the surface of our eye. The lacrimal fluid has antibiotic properties, you know, to kill bacteria that might get on the eye. It also cleanses the eye and moistens the surface. Moistens the surface of the eye. And it comes out around the location of the lacrimal bone. And there in the front, that little opening that we would think should normally be the mandibular foramen is actually called the mental foramen. And I know there's a story behind it, but I don't know it. So that's the mental foramen. There's one on each side. Okay, and it didn't label it, but that large bone right there at number 10, right behind the zygomatic bone, that's the sphenoid bone that goes all the way across. Okay. Now I was talking about the temporal bone and the openings in the temporal bone. You can see temporal bones on the side there. These openings are called these are the external auditory or acoustic meatus. It leads into a canal that goes through the bone of the skull, and the auditory nerve passes through that canal and then opens up deep inside the skull, right at the region of the brain where it has to be. There's our temporal bone, and you can see as it goes around, you can see the openings, the external openings there, and the temporal bone on each side. You know, you see your mastoid process and your styloid process. And when we get a little closer, you'll see there's a ridge. Let's see if I can, oh, that didn't do anything. There's a ridge across here. And within that ridge line, you're going to see when we bring the other picture up, that's where the auditory nerve passes as it goes from the outside of the skull deep into the skull to get to the brain. Again, there's your temporal bone there. So there's our occipital lobe again. Now the occipital lobe has a great big hole in it. It's called the foramen magnum. Foramen magnum means big hole. The foramen magnum is the opening for the spinal cord to come up into the brainstem. And usually where the brainstem ends and where the spinal cord starts is sort of problematic. You know, it just sort of, it all runs together at that point. But the spinal cord is about the size of your thumb, maybe a little bit bigger than your thumb at that point, coming up through the foramen magnum and joining with the brainstem. And at some point, we stop sending, you know, we move into the important reflex centers of the brainstem, and we're not part of the spinal cord anymore. But this is how we connect through that opening there. There's our occipital bone. Okay, now, and I already mentioned this about sutures. There's our sagittal suture line right there that divides us into a left and right side at the parietal bones. The coronal suture gives us an anterior and a posterior cut, if you will. Okay, and the sutures of the skull. This is a good picture of the sagittal suture looking straight down onto it. Parietal, occipital, coronal suture, and there's our sagittal suture dividing up again into both halves. Okay, now let's talk about the sphenoid. Let's finally get inside, look at the sphenoid. The sphenoid is a bat-shaped bone. It extends from one side of the skull to the other. It protects the underside of the brain, and it is the location of the pituitary gland. The pituitary gland is the master gland of our body, and it is in the most protected portion of the brain it sets right inside that little depression right in here. Now the ethmoid bone, this is part of the ethmoid bone up here. The ethmoid bone extends from the side of the eye sockets. The medial surface of the eye sockets extends upward into the base of the brain here, and then back down into the nasal cavity. So it's a fairly large bone. Okay, there's our sphenoid bone. You can just see, you know, the outer edges of the outside edges. Here's one here and over here, but we extend all the way across and down. Now the highlighted areas in green are what we call the lesser wing of the sphenoid. This is the area that looks like a bat wing, you know, or a batarang if you like Batman. But it's a very large, and then the rest of it is called the greater wing of the sphenoid. So, and we see it right here. This is the lesser wing up here. And this is the greater wing right below it. So this area here where we has number 53, that's called the sella turcica. There's the foramen magnum. And the sella turcica, or what we call Turk's saddle, and you can see it here in red as it goes around. It's shaped like a saddle, sort of, but that's where the pituitary gland is protected right in that region. So pituitary gland, as the master gland of our body, which controls the release of 8 different hormones, is pretty important to keep it safe. So we keep it inside, we protect it inside that structure right there, called the sella turcica. Okay, and again, foramen magnum, sella turcica. Now here we see something else in the middle of the greater wing of the sphenoid. We see 4 holes. The 4 holes, the 4 foramens are called, the outer 2 are called the foramen ovale, and the inner 2 are called the foramen lacerum. These are definitely passageways for cranial nerves. They go into the brain from somewhere, because the cranial nerves go into and out of the brain on both the left side and the right side, and that's what's passing through the foramen ovales and the foramen lacerums. Now, to remember what they are, you simply need to remember O-L-L-O, ovale lacerum, lacerum ovale, because that's the order. Now, excuse me. This picture here is pretty confusing. What it is, if you take your skull and take the top off the skull and then look down into it at a straight angle like this, and then tilt it at about a 45-degree angle, you're going to get that same image you see in the screen. If you can do that, and those 4 foramens are not visible anymore, then you're at the right angle. What you're seeing here is the optic foramen right up here, which you don't see very well when it's tilted flat. You also see another foramen down here called the foramen rotundum. You see an opening here that is the internal acoustic meatus. This is where the auditory nerve comes out. It has passed through this ridge line of bone right here. It goes into the bone at the surface of the temporal bone, at the external acoustic meatus, passes through that bone, through a canal, and pops out here, right at the region of the brain where it's supposed to be. This ridge line is called the petrous portion of the temporal bone, and it protects the auditory nerve until it gets into the brain. Okay. Now we see another foramen here on either side of the foramen magnum. This is called the jugular foramen. Any guesses what that's for? Jugular vein. Jugular vein is going to drain the head and a portion of the upper torso and blood's going to go back to the heart. So remember, veins bring blood away from the heart, arteries take them, veins bring blood to the heart, arteries take it away. Here's a very important little canal called the hypoglossal canal. Now, the hypoglossal canal is the passageway from the hypoglossal nerve from the medulla oblongata. Okay, I'm throwing a lot at you. The medulla oblongata is part of the brainstem. It's a reflex center. It controls our ability to do things like swallow. It controls our breathing rate. It can speed up or slow down our heart rate. But it's an important area for swallowing. When something hits the back of our throat, we swallow. A person that's had a stroke in the medulla oblongata usually can't swallow. But it's one of those subtle things, particularly if you're dealing with a dementia patient who can't communicate, because just because they can't swallow doesn't mean that they're not going to try and eat. And they might not, and they probably can't communicate to you very well. The problem with this is if a patient has damage in the medulla and their swallowing reflex is affected, every time they try to eat something or drink something, they're going to aspirate fluid into their lungs. And if that's not controlled, they can get pneumonia. And if you're dealing with an older patient, pneumonia is usually not a good situation you want to have them in. And if you're, a lot of times, if your patient can't communicate, the only way you're going to know that they had a stroke in the medulla is they developed pneumonia because they aspirated food or water. The hypoglossal nerve controls our ability to swallow. And if we, it's hard to pick that up, particularly if you're dealing with patients like in long-term care, where they don't like to eat anyway, or they're difficult to eat, difficult to get them to eat. So it's a very subtle indicator, red flag that something might not be going on. That's something that might be going on that's not good. Yeah.
How do you know if they've had a stroke?
Well, see, it's very hard. It's hard to tell that because
it's just like triggering me because my great grandmother just literally like 2 weeks ago got sick within 4 hours. I was with her, and she spiked a fever of 103, which she is older. But she like weighs maybe not even 120 pounds, but she won't eat. But the reason she won't eat is because she has a curved esophagus, which causes her to have trouble swallowing things unless it's either finely chopped up or she's chewed it until it's
right.
So she was in the hospital. They checked everything. They told her that her swallowing and everything was good. And that just kind of like makes me wonder. And she got pneumonia. She was aspirating food got into her lungs. That's caused her to have pneumonia. And that led to her having a UTI and all kinds of other things.
Oh, yeah.
So it just kind of like makes me wonder if that could be a thing causing that, because she doesn't like to eat because it scares her because she's choked.
Well, and the terror of choking amplifies the anxiety. My mom had a small stroke in her medulla, didn't know it. And every time she tried to eat something, she would start choking on it. And it took, actually, it was a speech pathologist that worked with her and taught her how to eat all over again. I mean, unless you've ever seen a homogenized hot dog, it's a sight to behold. But they taught her how to eat again because, it didn't cause a lot of damage, but enough that she couldn't swallow properly.
They told her that she also had back issues, so she's kind of hunched. They told her like to get in the best position upright possible to kind of stretch her esophagus straight, and then like after each bite, at least take a sip of drink.
Yeah, and that's
kind of push it down. But her problem was that she felt like it was getting stuck.
right.
But it was just, it wouldn't go down because they said her esophagus was closing, like contracting before the food was ready to go down. So it was closing her esophagus, and then it was leaking into her lungs, which caused her to get pneumonia.
See, we have a ring of muscle around our esophagus called the esophageal sphincter, and that's what closes when we're breathing, so we don't suck air into our belly. We don't want that. We don't want to inflate our stomach. So that ring only opens up when we swallow, and if it closes prematurely, then we end up with food and water left there, and then we take a breath, it goes into our lungs. And the subtle thing about pneumonia is that it takes several days to develop. It doesn't happen right away, you know. And so it's usually an indicator that something happened earlier. I know in my mom's case, it was very subtle. She was sitting at the table, and she suddenly dropped her plate because she lost control over it. And nobody thought anything of it, you know. Just she's old. I mean, come on, they do things like that, right? You know. No, I mean, it was just like an accident. But what that was the event there that determined it. That was the trigger. But it's very hard to spot that stuff. Now, if you're dealing with patients in long-term healthcare, they may fall, if they're in a wheelchair or in a chair, they may fall out of their chair if they have a stroke, or they may just drop everything. You don't know. You know, the flags are very, very subtle on that. So how's she doing now?
She's 84-year-old woman, might still get her hair done and stuff like that. But literally the day she got sick, she went and got a pedicure, drove herself to Jefferson City, everything. And then she was in the hospital for a little over a week. Came home and she was like super weak.
Mm-hmm.
But now she's actually getting her hair done right now.
So that's good. That's good. You know, quality of life is what it's all about.
I think it just upset her because, well, one, she's very, very independent. I mean,
Mm-hmm.
I want to be at that age too. And she takes care of my great grandfather who has dementia. So having to have like the whole family like help her and kind of like make her mad. But she still doesn't drive just because she's still super weak. But
Mm-hmm.
I've also been on her about eating because she would go all day and not eat and complain about not having any energy or anything. But she didn't want to eat because she was afraid of choking.
Right,
Like
right.
that. So, but she's doing a lot better than she was.
Well, that's good. That's very good. Yeah, this is more, you know, damage in that area is a lot more common than we think about. So who would think that such a little tiny nerve would cause so much trouble for us? So anyway, there's the hypoglossal canal. Thank you for sharing that too, by the way.
Just kind of like hit me to, I mean, that could have been.
Well, you're not, that's not, you know.
They said they didn't know
Mhm.
what happened or what caused it because obviously they said that her esophagus and everything was fine. So that just makes me wonder
Mhm.
if that could be something that triggered it off.
It could very well be. So, okay, there's that petrous portion again. It's a distinct ridge across here, and that's that opening for the auditory nerve right there. And that was the jugular foramen. Now, moving along, here we see the ethmoid bone. The ethmoid bone plays a role in olfaction. Our olfactory receptors are at the top of our nasal cavity on the inside. The little branches of the olfactory nerve pass up into the brain through the top of the ethmoid bone, which is perforated, little tiny holes punched in it. And then the nerves go through there. And that piece of bone is called the cribriform plate. And it sets right up here in the front, directly underneath the frontal lobe. And it's in the middle of our skull. I'll show you what here. The cribriform plate is along in here, and in the middle of the cribriform plate is a piece of bone sticking up called the crista galli. The crista galli holds the meninges in place. The meninges are connective tissue that surround our brain and allow it to float. They float, the brain floats inside the meninges. Our brain is not strong enough to support its own weight, so it has to float in cerebrospinal fluid. And so our brain doesn't go sloshing all over the place. The meninges are anchored at the crista galli, and that's that portion that sticks up. But on either side of the crista galli is the cribriform plate. If you look very carefully, you can see some of the perforations here. And that's the area we're looking at. 58 is the crista galli, and the cribriform plates on either side of it. You can see over here, the olfactory nerve is on either side of the cribriform plate. So the branches of the olfactory nerve coming up from the olfactory receptors inside our nose go straight up into there. Okay, crista galli and cribriform plate of the ethmoid bone there. Okay. Now, on the bottom of the skull, if you flip your skull over, you can see another opening. This is the carotid canal. That's where the carotid artery goes up to the brain. There's two branches to it. It's right next to the jugular foramen. There's the mandibular fossa. This is a flat area where the end of the mandible articulates. Fossa is flat area. We'll hear these terms again. This bone is called the vomer. It is the back half of the division of the nasal cavity. In front of the vomer is the palatine bone, and in front of the palatine bone is the palatine process. And it is actually the hard palate or the roof of our mouth. There's the palatine process of the maxilla. Stick your finger in your mouth and push up. You're going to press up against that bone. That's the roof. We call it the roof of our mouth, the hard palate. You know, you can see that leads into the maxilla itself, where the teeth are located in the upper jaw. There's our palatine bone there. And then, of course, there's the vomer right there. Foramen magnum, styloid process, mastoid process. Now, here's one other thing, the occipital condyle. A condyle is a bump. That's a technical term. Condyle is a bump of bone or a process of bone that essentially has a superior, inferior direction, meaning it goes up and down. So the bone, you know, the occipital condyle would have an up and down direction to it, straight up and down. The occipital condyle is what the skull uses to rest on top of the spinal cord. So if we take our skull on cervical vertebrae number 1, over here on our skull, on our skeleton, there is 2 fossa here, and these 2 condyles set here. Now, the only reason I mention condyles is because there's another type of condyle called the epicondyle. The epicondyle has a lateral or medial process. Sticks out to the lateral side or the medial side of a bone. We'll see those next week too. Okay. Yeah. The perpendicular, let's see, the labella is all that's left of the 2 parts of the frontal bone. It's right above the nasal bone. We can't even see it feel it on our skull, but it's there. And this is the front half of the nasal cavity. That is the perpendicular plate of the ethmoid. So this is the end of the ethmoid bone, finally reaching it in the middle of the nasal cavity in the front. The vomer is in the back. And there is the opening for the external auditory meatus leading into the auditory nerve. Now, on our fetal skull, pass this around if anybody wants to see this. This is life size. It's a model, but it's life size. You can see the bones are in place, but there are a number of soft spots here called fontanelles and suture lines. Here we have something we don't have in the adult skull, and that's a frontal suture. We have a sagittal suture at the parietal bones, but here our frontal bones haven't fused into one yet. So we have a frontal suture. We have our big soft spot, the anterior fontanelle. The fontanelle is a soft spot. Soft spot. that soft spot will stay there probably till we're about 20 years old, because our skull will continue to grow and change as we grow and change. It gives us a whole lot of flexibility when we're coming out of the birth canal too. There's the anterior fontanelle. Now, if we have an anterior fontanelle, we got to have a posterior fontanelle. And there is a posterior fontanelle on the posterior surface. I'll show you that in a second. Frontal bones, they haven't fused together yet. Parietal bones, right there. Frontal bone, there's the temporal bone. There's the coronal suture that still continues into the adult skull. Now this is one of the fontanelles. This is known as the sphenoidal fontanelle. This disappears as we age. There's another one called the mastoid fontanelle down there, the mastoid process. It also disappears. If we look at the top, we see the large anterior fontanelle, the big soft spot there. The frontal suture, which disappears. Coronal suture and sagittal suture. And looking at the back side of the skull, the sagittal suture, the parietal bones, the lambdoid suture, which still continues. And here is the posterior fontanelle, this little tiny spot right there. Again, if you have an anterior anything, you're likely going to have a posterior something. If you have a lateral something, you're going to have a medial something. So if you have a superior something, you'll have an inferior something. Just sort of a naming nomenclature on how anatomists have identified these structures. So, and I think that's everything. Oh, occipital bone. Okay, done with the skull. And we're done with today. So. Usually it won't last